welcome everyone. I want to welcome everyone to our final grand rounds of the FY26 academic year. Thank you. Just a couple of reminders. We will have our psychiatry engagement year in review on July 16th. It is a remote presentation by Dr. Forrester, and the link has already been circulated. So I want to remind folks of that. We have continued to do all our DEI work, but we call it the Department Engagement Committee, in line with what we've been asked to do from a campus level, to try to keep our nose below the radar of the federal government. But we've done an impressive amount of work, and we will have our update. Also for faculty that are here in the room and also online, just want to remind you we are having our May faculty meeting that was rescheduled for May on July 9th. And I had asked in my email for an RSVP. We've got 3 different work groups, and I'm ordering lunch, so I need to know if you are planning to attend so that I can order enough lunch. So I just wanted to remind you. So with that, I'm pleased to introduce our Grand Round speaker, Dr. Sesha Doty. He is an assistant professor and member of our geriatric faculty as our speaker today. Dr. Doty completed his medical school training in an integrated undergraduate and medical education program at Guntur Medical College in Antar University in India. I don't know if I pronounced that right, Doty. Dr. Doty. He then joined us in the U.S. for his postgraduate education, doing his first year at SUNY Stony Brook, New York, and then years 2 through 4 at Mount Sinai City Hospital Center at Elmhurst, New York. He is a board certified geriatric psychiatrist and has spent his career across several states with faculty appointments at many esteemed universities, including Mount Sinai, Albert Einstein, New York Medical College, and then joined our faculty in 2012, again as a member of our geriatric division. Over the years, he's established his clinical expertise in the delivery and teaching of ECT, the management of neurocognitive disorders in the geriatric population. And in 2024, he was instrumental in assisting us with the establishment of our Advanced Depression Treatment Center and the delivery of transcranial magnetic stimulation. And he's done a great job of getting us all trained, setting us all up, and getting us launched prior to his recent retirement. His latest interest revolves around today's topic in the use of focused ultrasound. So please join me in welcoming Dr. Doty as he presents focused ultrasound in the treatment of psychiatric disorders.
Thanks, Jill, for that gracious introduction. Okay. So, can you hear me now? Okay. Thanks to Dr. Akbaisal for that generous introduction. Good afternoon. Let me start by some disclaimers. Okay. I don't have any disclosures, no conflict of interest or no financial disclosure. This presentation provides an educational review of focused ultrasound application in psychiatry. Current evidence is based largely on recent pilot and early phase clinical studies. Findings should be considered preliminary and interpreted in the context of an evolving evidence base. At this time, no FDA-approved focused ultrasound treatment for psychiatric conditions, disorders. My interest, I have to tell you this small story. My interest started about 12 years ago about focused ultrasound. At that time, we had offices across from our neurosurgery colleagues. So Dr. Eisenberg was using Fox ultrasound for treatment of essential tremor. I think his study is one of the pivotal studies that got it FDA approved. And also came to know Rao Gollapalli. He's no longer with us. He deceased 3-4 years ago. And his team, radiation oncology and nuclear medicine. They were using Fox ultrasound to increase the permeability of the blood-brain barrier. So the chemotherapeutic drugs can be directly targeted to the lesions in the brain, such as malignant tumors. I spoke at that time, my immediate boss, Dr. Reginald, who is now at NIMH, discussed this, and I showed my interest about using it for treatment of depression. He added we should specifically target subgenial anterior cingulate gyrus, or Brodmann's area 25, which is very hard to reach because it is hidden so deep in the cortical folders. Only non-surgical way of reaching it is focused ultrasound. So we had a couple of meetings, and at that time, the company that is owns the system was applying for FDA approval. The company is only used to deal with neurosurgical staff. They were a little bit wary about letting us use in psychiatry team. On the top of it, we were 3 people in geriatric psychiatry at that time. One of my colleagues resigned. So Dr. Reginald and I were trying to manage geriatric inpatient unit, which used to be full all the time, and also a geriatric psychiatric clinic, which we inherited a lot of number of patients, and partial hospital program and ECT service. We got so busy, we put it in backhand, never able to come back. So my interest in presentation today is I'm hoping couple of faculty or junior attendings will take an interest and go into further research, which was my dream project, which I never able to start. So with that, let me jump into the topic. Okay, learning objectives. I will briefly talk about basic physics of ultrasound, and then focused ultrasound and magnetic MRI functionally monitored focused ultrasound. And there is a difference between diagnostic and therapeutic applications of ultrasound. We are all familiar with diagnostic ultrasound, so I will talk about both differences and similarities. Then we will talk specifical use in general medical field, and specifically some of the psychiatric conditions that the trials are going on at this time. My last slide will be about future directions and research opportunities. Okay, ultrasound. Human hearing is limited to somewhere from 20 to 20,000 hertz. Very simply, it is the frequency of these waves per second, that is hertz. Ultrasound is about 20,000 hertz. That means it is beyond human hearing. What happens when you focus this focused ultrasound? The ultrasound target depends upon various other physical parameters. So this is diagnostic ultrasound. This is what they call transducer. We are all familiar. It is used very commonly imaging pregnancy and thyroid nodules and a lot of other day-to-day. Nowadays, all our ER physicians and residents carry the portable one, and they do quite often use it. And I saw the anesthesia people using it to start the phlebotomy, because in difficult cases where you cannot access the artery or the blood vessel. So when you send these ultrasound waves towards the targeted organ, let us say uterus or kidney or kidney stones, the rays go and touch the organ and bounce back. It is like an echo. Again, more or less, it is like a ball. We are bouncing it on various surfaces. The reaction will be different if you bounce it on a concrete or wooden floor or carpeted floor or in water. So the transducer catches those bouncing waves and analyzes and converts them into images. That is what our diagnostic ultrasound is. When it comes to treatment, it is a little bit different. It is like you direct various ultrasound waves with different intensities towards a single pinpoint lesion. It is so accurately can pinpoint up to 2 to 3 millimeters diameter. So it is like we used to play when we were kids. I don't know whether these generations know about it. Sunlight, we used to use a magnifying glass and focus it on a tissue or a paper. Either it can warm up, or if you use it too long, you can create a fire. So more or less, same principle applies here by sending focused ultrasound from different directions, targeting in the same area, and you can produce heat or you can destroy the tissue very precisely, 2 to 3 millimeters diameter tissue. That is the focused ultrasound treatment. Okay, like I said, there are two different main approaches. There are in between others, but I just want you to remember high intensity focused ultrasound, where you actually destroy the precise area. It is generally used for treat the brain tumors or capsulotomy, whereas low intensity does not destroy the tissue, it modulates neuronal circuits like what we call neuromodulation. And it can also, in between, it can also open blood walls of the brain blood vessels to open the blood-brain barrier for delivery of the drugs. And in practice, it is done with MRI guidance. So it is precise and very targeted, and it also measures the heat that is producing. Okay, this is typical setup of MRI-guided focused ultrasound treatment for brain lesions. This is actual treatment. This is the way it looks if you go into setup. It is very sophisticated and also needs a lot of expertise to use. Fortunately, our neurosurgery department has extensive experience using focused ultrasound. Again, mechanism of action, if it is high intensity, it actually destroys that small tissue, which is called thermal ablation. Low intensity, it is mechanical and a little bit more complicated other mechanism. It produces neuromodulation. Okay, I want to introduce you to foundation called Focused Ultrasound Foundation. This is a nonprofit organization that has been advocating for usage of focused ultrasound in various medical conditions. They provide seed money if you want a pilot project. They collect the information from all over the world and they disseminate this information. So I skipped this slide, but this is figurative way of showing focused ultrasound effect, neuromodulation with low intensity, high intensity destroying the malignant tumors, and in between opening the blood-brain barrier, and so the chemotherapy drugs can deliver directly to the malignant tumors in the brain, and it can also be used in theoretically for removal of amyloid plaques in Alzheimer's disease, and it is also applications for gene therapy. Okay, Ultrasound Foundation, they have a newsletter. In 2024 newsletter, they listed 178 indications in medical field. But if you focus closely, most of them are preclinical or pilot trials. Very few of them progressed to clinical use. And our FDA only approved 11 conditions. None of them are for psychiatric conditions. We are very conservative. So instead of reading 178 in this list, let me just give example: cardiovascular, cardiac, atrial fibrillation. You can modulate the Purkinje system, peripheral venous or peripheral arterial system, varicose veins treatment, endocrine such as thyroid nodules, gastrointestinal pancreatic tumors, neurological, essential tremor, which is FDA approved, Parkinsonism disease, and again, neurodegenerative Alzheimer's, or pain, certain type of pain disorders where there is a focus, and tumors, brain tumors, and vascular, if somebody has a stroke or thromboembolysis, you can use it non-invasively without surgical intervention. Glaucoma treatment by ophthalmologist. Urological, benign prostate hyperplasia, FDA approved, prostate cancer, kidney stones, and women's health includes fibroid tumors without surgery, and breast tumors. So our FDA only approved 11 of these indications. None of them are psychiatric. They include back pain, benign prostatic hyperplasia, bone metastasis, bone tumors, and essential tremor, kidney stones, liver tumors, osteoid osteoma, Parkinson's disease, prostate cancer, and uterine fibroids. If you notice, none of them are psychiatric conditions. Why do we need focused ultrasound in psychiatry? We already have dozens of medications. We have therapies, proven therapies, psychotherapy. And we also already have ECT, which is a gold standard still for the treatment of severe major depression and psychotic depression. And also we have now transmagnetic stimulation, esketamine treatment. Why do we need another tool? Let us look at the facts. Unfortunately, most of the conditions we cannot cure or not even complete remission. We have a response rate. And I also want, especially the residents, pay attention whenever you are hearing the topics. The word response rate is 50% reduction from baseline symptoms, whereas remission is completely symptomatic, even though they can have another episode in between complete symptom-free. And those of you who are familiar with STAR-D study know after 4 levels of steps, still there is a significant number of people with residual symptoms. In clinical practice, we see always these people who are partially treated, partially remitted, try to go back to work. Their productivity is down. Their marital relations go down, interpersonal. Their social functioning, interpersonal, vocational, educational, the quality of life goes down. So we need more tools. That is the reason we should consider focused ultrasound as another tool for treating psychiatric condition. The advantage of focused ultrasound is it is non-invasive, precise targeting. You can target it very precisely, and there are structures that are only available by surgical intervention. So focused ultrasound can reach deep brain structures. TMS, transcranial magnetic stimulation, you can only penetrate 5 to 6 centimeters from the brain surface. It is also not like laser. The wave is like a cloud, so it is not precise. Whereas depression, most of the people believe that depression, most of the severely depressed people, there is a lesion mostly in the subgenial anterior cingulate gyrus, also known as Brodmann's area 25, which hyperactivity, there is excessive neuronal firing. It is impossible to reach that area, and focused ultrasound gives us a chance to do some neuromodulation directly at the area rather than secondary targets. So current trials, again, all the next few slides talk about the trials, most of them done internationally. 12 years ago, when I thought about it, there is only one published pilot study with 4 patients from a group in Korea. Nobody else was doing or no other published studies. When I started preparing for this presentation a couple of months ago, I put open evidence and I got something like 24 articles. Most of them are in last 2 to 3 years published. Now I'm just sitting and looking at, since I prepared this, there are 2 or 3 more publications. So every month the publications start appearing. There are a lot of unanswered questions, but the brain areas, the psychiatric disorders that are mainly being studied at this time is obsessive compulsive disorder, major depressive disorder, anxiety disorders, substance use disorders. There are others, but they're just in the theory. None of them went on for the pilot studies. Brain areas targeted for ablation or neuromodulation. Ablation is we actually focus and destroy the tissue, whereas neuromodulation is we modulate by stimulating the neurons or circuits. Anterior limb of the internal capsule for OCD and depression and addiction. Nucleus accumbens for addiction. Inferior thalamic peduncle for depression OCD. Medial forebrain bundle for depression OCD. Centromedian nucleus of thalamus and globus pallidus for Tourette syndrome. This is diagrammatic representation of various areas that are focused, brain areas, focus or targets for ablation. Again, I'm going to just talk about obsessive compulsive disorder next couple of slides. Again, most of the published OCD studies are in the targeted anterior limb of the internal capsule. The white matter tract that connects prefrontal cortex to subcortical structure, including thalamus, is the target. If you use ablation and take out that white matter tract, you can do capsulotomy without doing surgical intervention. Surgical intervention, capsulotomy, has been in the field for a long time, but it is actually doing brain surgery. Here you can do the same thing with focused ultrasound. So most of the studies, almost all the studies, target high-intensity focused ultrasound for ablation. These are the 5 studies I was able to get my hands on a couple of months ago, and I summarized them in this table. So if you notice, number of participants in all these studies are very small. None of them are sham controlled. None of them are double-blind. And the focus is mostly the anterior limb of the internal capsule or capsulotomy. The preliminary data is BIBOS scores for obsessive compulsive symptoms score, and 33% improvement in the score is considered as a response. So 33% from when we talk about these things, I always laugh because most of the depression studies, we say improvement, 50% improvement in Hamilton or Montgomery scales. But in our inpatient, you have people with 50 out of 60. So if they come to 25, the score, it is patient is in remission. No, patient responded. But 25 is still severe major depression. You can enter into studies with 25 score. So you have to pay a little bit more attention about this response, what they call. So here 33%, which is modest, but for OCD, which is a difficult disorder to treat. Again, it is a small sample size. The summary, it talks about 8 articles. All studies involve anterior capsulotomy with small sample size. None are double-blind or sham-controlled. It yielded roughly response of 67% of the patients, that is defined as 35% or more reduction in the VIBOS scores. The largest study has 15 patients. The most important outcome of all these studies, safety profile. All the studies, there are no serious adverse events. There is mild transient side effects, such as a transient headache, penicyte swelling, and nausea. They resolve without any intervention. They studied very carefully for cognitive effects. After the study, 1 month after the 1 month after the intervention, 6 months after, with sophisticated neuropsychological testing, they were not able to detect any effect on the cognition, which is a good plus. There was weight gain noted in some patients following capsulotomy in OCD. Long-term safety data extending 18 to 24 months so far confirms the absence of serious adverse reaction in the small sample size of the studies. For depression, there are 2 approaches, both high intensity, where you can target the same areas on the brain, same targets as obsessive compulsive disorder. But most interesting one is low intensity focused ultrasound, where you do not destroy any tissue. It is mostly neuromodulation. So if you look at this study, the first study that was published when I was looking for the studies 12 years ago, the only study is from Korean group, proof of concept with 4 individuals, 100% response at 12 months. Too good to be believed, but that is the very first study using psychiatric for treatment of psychiatric disorders. Last 3-4 years publications included neuromodulation. There is 1 study with sham controlled, even though the number of subjects is 22. And I summarized all the studies which I reviewed. These are 5 studies which I reviewed. Again, sample size 6 to 12, 20 to 1, but this is the largest study with healthy controls and sham treatment. And the target is anterior, same as OCD, except for the capsulotomy. But whereas the last 2 are anterior medial prefrontal cortex. The summary with high intensity focused ultrasound, 33 to 42% across from all the studies, 50% or more reduction in Hamilton depression scales. Low intensity neuromodulation, improvement in mood scores within 24 hours, 60.9% reduction in 1 study by day 5. 4 out of 5 patients qualified as responders in another study. Again, look at the small sample size. And there is a lot of heterogeneity in the studies, which I will come in my last slide. Generalized anxiety disorder, there are only 2 published studies, both of them targeted amygdala, and there is reduction in the Hamilton anxiety scores. 2 studies for substance use disorder, mainly opioid, they are also using other substances in addition to opioid. And both studies, the focused target is nucleus accumbens. And those in probably our addiction treatment division can appreciate 91% mean reduction in Q-induced opioid craving. It is technically saying there is some improvement. This is summary of all the generalized anxiety, substance use, and opioid use disorder, which I already mentioned. So what are the advantages and safety profile of focused ultrasound? It is non-invasive, there is no incision, no anesthesia, no implanted hardware like some of the surgical procedures where implant various probes. It is high precision, real-time MRI guided. Recovery time is practically none. It is well tolerated across all the psychiatric studies. No cognitive issues, both in short-term and long-term follow-up, even though the total number of participants is small. There were some theoretical concern. Some of the international groups expressed concern that if you do repeated high-intensity treatments in the brain, it can lead to hemorrhage, cell death, and unintentional blood-brain barrier opening. These are only theoretical. None of these things happened in any of the studies. But to be on the safe side, all the studies now they advise to exclude people with compromised thermoregulation, vascular vulnerabilities, that is repeated hemorrhagic strokes, skull density ratio less than 0.4. Because if it is less than 0.4, the intensity and penetration will be more. So what are the limitations? Way ahead. So lack of double-blind or sham-controlled trials, small sample size, none of them are FDA approved for any clinical use. There are limited availability, only big research centers. It can be done, and it needs a lot of expertise. It's very costly between MRI guidance and the equipment. Long-term efficacy data are still emerging. So it is a promising non-invasive alternative treatment for treatment-resistant psychiatric disorders. This is the interesting part. I think our department should consider collaborating with our neurosurgery colleagues. They are expertise, they have a lot of experience, and they are interested. And somebody has to spend time and tolerance. My experience from conducting the NMS-sponsored study in the early year of my career is I was doing exclusively all my time doing the study, except for small fraction for performing ECTs. So it is impossible with clinical duties to combine research study, and it is also frustrating. Our study took more than 10 years by the time we published. Some of those findings became irrelevant. So it is a lot of things, even basic things we had established. That is frequency of the treatment sessions. All the studies, they used variable. Is it daily, weekly, or how many number for each session? What is the optimal duration of the treatment? What about the intensity of the waves? And also scope of treatment. For example, people are talking about post-traumatic stress disorder using it. Okay, no studies. So there is really a lot of opportunities for young clinicians who are interested in research. And we have this opportunity because of our neurosurgical department. So we should collaborate. I know Dr. Marano spoke to them a couple of times, but I think somebody has, Dr. Marano is so busy. I feel bad for him. But somebody has to take a lead and interest and jump into it. So that is actually my dream project, which I was never able to do. So my intention of this presentation is at least stimulate a couple of people to get some interest. These are all the 24 review articles I studied. I just checked it to open evidence. This was two months back, and there are a couple of review articles and couple of other publications since then. So there is plenty of time left. This is the first time I ever finished any grand round presentation within 30, 40 minutes. Any questions? Again, I'm not an expert, so I know there are other people who know more about Foxed ultrasound. I also put my email if somebody wants any of this material or any discussion, share any ideas, please feel free. So any comments, questions, suggestions, appreciate.
Any questions online, Zach?
Is FUS offered in our ADEP clinic? If yes, what has been the experience?
No.
Right, again, at this time, you cannot use clinically. It is still in the preliminary stages. Only few research centers are doing it in all over the United States as part of the research protocol. So if we want to do research study, we have to submit the protocol for IRB and also get some funding because these are the costly treatments, except our neurosurgical department already have all the necessary equipment and experience and expertise.
Are there other universities? Do you know of any other university running a study in psychiatric disorders now?
I think Stanford
Stanford is.
and somebody in Texas is doing it. And last time when I checked.
Other questions for Dr. Doty? Thank you very much.
Okay, thank you. I could never push myself and push the project. I had this in my idea.
I know.
My dream. I wanted to be the first one to publish.
It would definitely have to be, I mean, it's clearly investigational, it would have to be spearheaded by an oral one.
Yeah, and also somebody has to spend all the.
Yeah, exactly.
And it is, and I was once supported with kind of dose. Our study is the first one that got down the dose from 120 milligrams.